Welcome to the Structured Operative Obstetrics course on surgical detail for cesarean sections. This presentation aims to educate healthcare professionals about the provision of cesarean section. It will cover the essential steps involved in performing a cesarean delivery, highlight the indications for the procedure, and discuss the necessary preoperative and postoperative care. A cesarean section is a surgical procedure used to deliver a baby through incisions in the mother's abdomen and uterus. Providers use it when they believe it's safer for the mother, the baby, or both. A cesarean section can be performed in an emergency or as a scheduled case. If it is the first cesarean section, it can be called primary, or if there has been one or more before, it is called a repeat cesarean section. There are several indications for cesarean section. Some women will be advised to have a cesarean section without ever laboring, as is the case of patients with a transverse fetal lie, or if they have placenta or vasa previa. Women with medical conditions like heart problems, where it would be unsafe for them to push due to stress on the heart, are another example. Sometimes, cesarean birth becomes necessary during labor, for example, when there is a cord prolapse at the time of rupture of membranes, if the labor is not progressing, or if the fetal heart rate is abnormal. Cesarean birth may also be recommended if there is concern about fetal growth or severe preeclampsia, when there is not enough time to induce labor. Patients may also be advised to have a cesarean birth if they have previously had surgery on their uterus, including myomectomy or previous cesarean birth. A thorough assessment of the mother's health, including medical history and current conditions, is essential before surgery. The surgical team prepares the operating room with the necessary instruments and ensures all team members are ready. Informed consent involves discussing the procedure, its risks, benefits, and alternative options with the patient. Anesthesia may be regional, such as epidural or spinal, or may be general anesthesia based on urgency, patient needs, and medical recommendations. The usual prophylactic antibiotic is cefazolin 2 grams, or 3 grams if weight is over 120 kilograms. This significantly reduces the risk of infection. Let's discuss the key surgical steps involved in a cesarean section. The surgical procedure begins with an incision in the abdominal wall. The skin incision can be made suprapubic transverse or midline vertical. A vertical midline incision can provide faster access to the abdominal cavity, and it disrupts fewer tissue layers and vessels, so may be the preferred method to perform an emergency cesarean. However, a transverse skin incision is often the most used and is preferable in most cases due to improved wound healing with less dehiscence and a better cosmetic result. The phalansteal incision is made about 2 finger breadths above the pubic bone. The skin incision should be 12 to 15 centimeters long, and it is best to cut through the dermis and epidermis with a single sweep of the scalpel. The subcutaneous layer, located just beneath the skin, can be dissected using blunt or sharp techniques. However, it is important to be careful because blood vessels are present throughout this layer. To minimize blood loss, surgeons should limit sharp dissection to the midline until reaching the fascia. Once the fascia is reached, switch to blunt dissection when working laterally. This approach helps reduces the risk of excessive bleeding. Techniques for opening the fascia during cesarean section differ based on the primary incision type. This image shows how you would open the fascia when the incision is transverse. Make a small incision using a scalpel near the midline of the abdomen. You should be able to see the rectus muscles on either side of the linea alba, which confirms where the midline is. Extend this incision laterally using heavy curved Mayo scissors. To avoid lateral structures and bleeding, you should curve your incision upwards at the lateral edges. If the patient has had no prior abdominal surgical procedures, you may choose to bluntly extend this facial incision. This method involves gently spreading the layers of fascia apart with your fingers, which can provide faster access and help minimize trauma and bleeding. Sharp dissection may be required for a patient with adhesions due to previous surgery. Once the fascia is open, the muscles naturally split in the midline. You may need to separate them off the fascia if you are entering with sharp dissection and not blunt. The peritoneum can be entered bluntly, or it can be grasped and pulled up with 2 hemostats and cut between them to create an opening. Ensure there is no bowel right below the peritoneum prior to cutting. Cut an opening in the peritoneum that is just large enough for your finger. The opening can then be stretched bluntly and additional room can be made with scissors as necessary. The next step involves opening the peritoneum, overlying the bladder and lower uterine segment. This step provides adequate exposure of the lower uterine segment and allowed the bladder to be pushed downward, decreasing the chance of accidental injury. Start by identifying the vesicouterine fold of the peritoneum, which lies between the bladder and the uterus. Good visualization requires an empty bladder. Grasp the peritoneum to lift it off the uterus and find a thin plane. Make a small incision here. This initial cut should be done cautiously to avoid penetrating too deeply and injuring underlying structures such as the bladder or causing bleeding. Metzenbaum scissors can be used to extend this incision laterally on both sides, and blunt dissection can be used to separate the bladder off the lower uterine segment. While opening the bladder peritoneum is a routine part of cesarean sections, several factors must be kept in mind to avoid complications and ensuring patient safety. In the operating theater, the patient will lie tilted to her left side to avoid hypotension from compression of the aorta and vena cava. With this left lateral tilt, the uterus may twist even further to the patient's left. Once the peritoneal cavity is open, look at the lower uterus and also reach up toward the uterine fundus to feel how much the uterus has twisted. This helps to be certain that the midline of the lower segment is identified and the peritoneum is entered in the midline and not off to the right side where bleeding is more likely. Scarring from previous cesarean sections is a common issue that can complicate subsequent surgeries. Adhesions from prior procedures can obscure normal tissue planes, making it challenging to open the bladder peritoneum safely. In general, by being aware of these adhesions are likely to be present and employing careful surgical techniques, we can minimize risks and improve outcomes for our patients. The uterine incision is typically made in the lower segment of the uterus, which is less vascular compared to the fundus, thus reducing the risk of excessive bleeding. A transverse incision is made in most cases. Reasons for other types of uterine incisions were discussed in the Surgical Principles Lecture Number 9. A low transverse uterine incision also heals with the most strength and is the least likely incision to rupture in a future pregnancy. Before making any incisions, check the position of the uterus and ensure that you are oriented correctly in the midline, remembering the patient is tilted to her left. Accurate identification of the midline ensures that the incision is made symmetrically and in the least vascular area. It reduces the risk of damaging adjacent organs, such as the bladder. Make a transverse uterine incision just above where the bladder has been reflected downwards. Remember that the baby's head will be right below this incision. The uterus can be very thin here, especially if the patient has been in labor. To avoid cutting the baby, make a very small and superficial incision in the uterus first. Then step by step make this small incision a little bit deeper until the amniotic membranes are seen. Cut through the membranes or make a hole in the membranes with a toothed forceps, being very careful to avoid cutting the baby. After making the initial incision, some surgeons will score the uterus in a curved line, resembling a smile. This technique helps direct tearing away from the uterine arteries, which are lateral, when the incision is bluntly extended. The hysterotomy can then be extended laterally or in a cephalad-caudad direction. Usually we avoid lateral extensions to decrease the risk of the hysterotomy tearing laterally through the uterine arteries. Delivering the fetus. Reach into the uterus with the dominant hand to determine the position of the fetal head. The goal is to identify the occiput and flex the head to gently get it into the easiest position for delivery through the uterine incision. In some cases, it may be necessary to disimpact the head if it is lodged deep in the pelvis with obstructed labor. This was discussed in the preparation for cesarean section lecture number 10. Once the fetal head is positioned correctly, an assistant provides fundal pressure to aid in delivery. Fundal pressure involves applying pressure to the top of the uterus, which is called the fundus, to help guide the descent of the fetus through the incision. After the fetus has been delivered, it is standard practice to administer oxytocin intravenously. Oxytocin is a hormone that stimulates uterine contractions. Administering oxytocin helps the uterus contract effectively to help expel the placenta and reduce the risk of postpartum hemorrhage. Some centers may have access to a synthetic, long-lasting version called carbetocin, which is also heat-stable. Once the baby is fully delivered, The next step is to clamp and cut the umbilical cord. The cord is clamped in two places. The segment between the two clamps is then cut with sterile scissors. This step is usually done after a delay of 30 to 60 seconds if the fetus is vigorous and there is no maternal concern. The placenta is delivered by gentle traction on the umbilical cord. Theirs is less bleeding and less risk of infection if the placenta is delivered by cord traction instead of being removed manually. However, if you need to deliver the placenta quickly, you can remove it manually by reaching into the uterine cavity and separating it from the uterine wall. If the uterus has not contracted down well at this point, massage the fundus while second-line uterotonics are prepared. Once delivered, examine both the uterus and placenta. The surgeon should check the surface of the placenta to see if any parts appear to be missing. Reach up into the fundus of the uterus to be sure all of the placenta and the membranes have been removed. Ensuring that no placental fragments remain is very important in helping to prevent infection and postpartum hemorrhage. Once the placenta has been removed, the next step is to close the uterus. The first decision to be made is whether you will exteriorize the uterus. Exteriorization involves bringing the uterus outside of the abdominal cavity for closure. In contrast, intraperitoneal repair involves closing the uterus while it remains inside the abdominal cavity. The choice between these techniques should be guided by individual patient circumstances and surgeon preference. Removing the uterus from the intraperitoneal cavity allows for better visualization, especially of the lateral ends of the incision, where there may be extensions of the hysterotomy incision and bleeding. However, there is a higher risk of infection as well as more patient discomfort and nausea. Leaving the uterus in the abdominal cavity may be necessary too if there are large fibroids making exteriorization difficult. The first step in closing the uterus involves using green armitage forceps to clamp the edges of the uterine incision. This is where the hysterotomy tends to bleed the most, so by clamping these areas you will decrease blood loss. These forceps are specifically designed to grasp and secure tissue effectively, providing a firm grip on the uterine edges. Clamping helps to stabilize the tissue, allowing for better visualization of the ends of the uterine incision and ensuring that any bleeding can be controlled as you proceed with closure. After clamping, assess the corners of the incision for any extensions that will need to be repaired. The next step involves using a running suture technique with Vicryl 1 or an equivalent suture material. The sutures should be placed approximately 1 centimeter apart, ensuring that they penetrate all the way through the myometrium. The first and last sutures should be placed beyond the apex of the incision to be sure any blood vessels which have retracted are occluded. Throughout the suturing process, it is critical to continuously assess and ensure hemostasis as you go along. This involves checking for any bleeding from vessels as they are encountered and taking appropriate measures to control it. Also recheck the tone of the uterine fundus periodically. Massage the uterus and ask the anesthetist to give extra uterotonics if needed. This is what a running suture on the hysterotomy would look like. The deeper layer in this diagram shows a running stitch which is not locked. The second layer shows a running locked stitch. After completing the first layer, assess for any bleeding and be sure that hemostasis has been achieved. This minimizes the risk of hematoma formation or infection. Uterine closure after a cesarean section can be performed using either a single layer or double layer technique. The double layer closure method involves closing the uterine incision in 2 distinct layers, which is traditionally considered to provide better support and healing by ensuring that all layers of the uterus are properly approximated. Research indicates that double-layer closure results in thicker myometrial thickness and may reduce complications associated with uterine scarring in future pregnancies. Conducting a thorough assessment before closing the abdomen during a cesarean section is very important. Ensure that there are no actively bleeding vessels from the hysterotomy, especially at the corners. Then, check the bladder flap, which means the area where the bladder has been retracted down to be sure there is no bleeding. You should also assess ovaries and tubes for any abnormalities, particularly ovarian cysts. A surgical count of instruments and sponges is done as well to ensure they are all accounted for before closing the abdomen. There is little benefit in closing the bladder peritoneum. Regarding closure of the parietal peritoneum, certainly, it is faster to avoid this step. However, some surgeons have found that there are fewer adhesions of the uterus and bladder to the muscle of the abdominal wall when the peritoneum is closed. Once hemostasis of the rectus muscles, peritoneum, and uterus are confirmed, we can move on to the next step, which is closing the fascia. The fascia is the main strength layer of the abdomen and should be closed with a strong delayed absorbable strong suture, such as Vicryl, in a continuous manner, not locking. Aim for the sutures to be 1 centimeter apart and 1 centimeter into the tissue on either side. You want to bring the edges together without causing necrosis of the tissues, which may be more likely with a locked suture. The subcutaneous layer, which consists of fatty tissue beneath the skin, plays a significant role in wound healing and overall recovery. Adequate closure of this layer can help reduce complications such as hematomas, seromas, and wound dehiscence. If the subcutaneous fat is less than 2 centimeters, studies suggest that closure may not significantly impact outcomes, so it is usually only reapproximated if it is thicker than this. This layer can be closed with interrupted sutures. Proper skin closure will help minimize complications such as infection and ensure optimal cosmetic outcomes for the patient. The skin can be closed with staples or sutures. If using sutures, the subcuticular technique involves placing a continuous suture just beneath the skin layer. It provides excellent cosmetic results with the least visible scarring. Absorbable sutures are usually preferred since they do not need to be removed. Then, confirm again that there is good hemostasis and apply a sterile dressing. After closing the uterus during a cesarean section, it is essential to evacuate any clots using gentle fundal pressure. Complete the third section of the surgical safety checklist. Document all relevant details in an operative note along with post-operative orders, and communicate with the patient and their family about how the procedure went. While cesarean sections can prevent complications, they also carry risks such as infection, longer recovery time, and blood loss. After surgery, patients are monitored closely for vital signs, bleeding, and pain management to ensure safety and recovery. Pain relief strategies include medications and non-pharmacological methods to enhance comfort during the recovery phase. Planning for skin-to-skin contact as soon as possible can positively influence bonding between mother and child. Proper wound care decreases the risk of infection. Patients should be educated on signs of infection and proper hygiene practices, and both when and where to return if there are concerns. Recovery involves gradual return to normal activities, with follow-up appointments to monitor healing and address any concerns. It is very important to discuss with the patient how this delivery by cesarean section will affect the safety of future pregnancies and the care she will need. In summary, cesarean section is a life-saving surgical procedure, but is also a major abdominal surgery that involves incisions in the abdomen and uterine muscle to deliver baby. After delivery, the uterus and abdomen are closed with sutures, and hemostasis must be ensured at every step. Healing from a cesarean section requires good care of the incision to prevent infection, minimal strenuous activity for 6 weeks to decrease risk of wound or facial dehiscence, and good pain control.